Okay, hello everybody. Today I'm basically going to make one point, or talk about one concept or principle, and I'll be elaborating a little on some practical measures that we're taking in response to that principle. Hopefully you'll get the point by the time I'm finished. So first of all, why do we monitor? Well, I think broadly there's two important reasons why we monitor. First of all, whether we're working in government or we're working with some technical assistance agency, invariably we're accountable to somebody. We're accountable, for the use of funds. We have to be able to show that whoever we're responsible for, that we're delivering. So this is an important function. It's for accountability purposes. In the second place, and again, wherever we sit in the system, and whether you're working at the national level, whether you're working at the district or local level, by monitoring, in principle, that can give us an opportunity to see what's really happening with our programs and services. So, and on the basis of that, then we can figure out, well, what do we need to do differently if there's some performance problem? So we make use of monitoring data ourselves, so that the services and programs that we're responsible for, that we take responsibility to make sure that they're performing better. So we monitor for others that we're accountable to, and we report, and at the same time we monitor for ourselves so that we can improve our own effectiveness. Now, specifically with maternal health program performance monitoring, you're all very familiar with this. This is the MDG, the overall MDG goal 5 is to reduce mortality. Now, maternal mortality doesn't get measured very often, and it doesn't get measured with very good precision. This is a very important number for us in any of the countries that we work in, but it's not exactly a monitoring measure. The common monitoring measures, these are these secondary or intermediate MDG indicators, and specifically for maternal health, the two key ones, and we see these all over the place. Anytime you see brief discussions of program performance in maternal health, you hear about what's the skilled birth attendance rate, or what's the antenatal care, the ANC1 or ANC4 rate. And in kind of a shorthand discussion, like when we're talking about the status of a maternal health program, we say, oh, well, our SBA rate was 38% 6 years ago, and now it's up to 52%. And then that's taken to be the last that you need to say about maternal health program performance. A number of you are aware, just over the last year and a half, the Secretary General has a new initiative. This is a Commission for Information and Accountability for Women's and Children's Health. And similarly, there were a number of indicators that were elaborated, not that much different than these secondary MDG indicators, and you see the same skilled birth attendance indicator. Now, the question mark there. My question to you is what's wrong with that picture? Again, understanding that the reason why we monitor is to have some idea of what's actually going on, as a basis for us to make decisions so that we get better performance, better real performance. Well, what I would put it to you is what's wrong with that picture is that skilled birth attendance indicator tells us very little. In the first place, it doesn't tell us anything about the actual skills of the provider who attends the delivery. So it's actually a misnamed indicator. So what it says it's measuring is actually not the case. So, I mean, you think about how SBA attendance is measured. Now, it's measured every 5 years or so through a DHS, where you ask a woman, well, who delivered you? And then she'll say, oh, it was a doctor, or oh, it was a nurse. Well, I mean, that may or may not be accurate. The woman may or may not know the professional qualification. She probably recognizes that the person was wearing a white coat, and probably can reliably differentiate between somebody who's a professional health worker and somebody who's not. On a year-to-year basis, many countries monitor skilled birth attendance rates, And how do they measure it? Well, they arbitrarily define certain cadres as being skilled birth attendants. And so any delivery that's attended by a professional in one of those cadres is considered to have delivered with a skilled birth attendant. And that goes into this SBA delivery rate. Now, what skills do those providers actually have? Well, we don't know. I'll tell you, I'm a physician, and I was doing deliveries up until 15 years ago. I haven't done any since then. Now, I might meet the definition of a skilled birth attendant for HMIS purposes. Would I volunteer myself to come and deliver your daughter-in-law if she was having delivery? No, I would not. I don't consider myself at this point adequately skilled to do that. So now, in the second place, even if the provider has the skills, at the end of the day, what results in reduced mortality risk is not the supposed skills of the provider, it's what's actually done. Okay, but we can get into that discussion another day. But my point here is that skilled birth attendants measures basically a contact with the system. So the woman delivered, there was a health professional there, what was done, we don't know. So, and this is the principal indicator that we use at a global level for tracking year to year how our programs are performing. So I would put it to you that that's not really good enough. And that in monitoring or tracking overall performance of our maternal health programs, we need to be taking a closer look at what's actually happening. So the content and the quality of care. So anyway, you'll hear me repeat that. That was my main point. So if you fall asleep for the remainder of my talk, then that's okay, because my job's already done. So why does it matter what indicators we use? Well, I would put it to you that, again, what we measure is what we pay attention to. And contrary-wise, if we don't measure it, we're going to be inclined not to pay attention to it. If we tell program managers at national level, at district level, at local level, that what we really care about is your SBA delivery rate or your ANC1 and ANC4 rate, well, that's what they're going to tend to pay attention to. And they're going to tend not to pay so much attention to content and quality of care. So I think, it's important for us to distinguish between measuring a contact and measuring what actually happens, so the content and quality of care. And the indicators that we use, and I'm not sure that we normally think of them in this way, but one very important function of these indicators is that they send a signal to program managers. That being the case, it's important that we're sending appropriate signals. So if we want program managers to care about and give attention to content and quality of care, well, then we need to be using indicators that better reflect content and quality of care. Now, I'm not the only person who believes this, and we've got, I think, a lot of other people who work in maternal health and maternal health measurement, and we've been in kind of active discussion around these issues over the last several years. We've had a process going on with colleagues at WHO over about the last year and a half, and we're at a stage now where we've got a number of products that are in the works. In the upcoming MDG Countdown report, we have a panel that we've developed around quality measurement that'll be incorporated, and some specific suggestions about indicators to be used. What we've tasked ourselves with is to come up with a very limited set of indicators that better reflect content and quality of care, and that in principle are simple enough that it should be possible to incorporate them into any health management information system. So that's our goal. Now, these are not perfect indicators, they're not ideal indicators, they don't give us a full picture of quality. But the idea is at least to do more than monitor SBA delivery, and to begin to send clearer signals to program managers that they need to focus on content and quality. So I'm going to spend the next few minutes, I'm going to go over the specific indicators that we've come up with, and I'll talk about what we're expecting to do with these. Now, the first one is one that we've already heard about. In João Paulo's presentation, he mentioned that in the recent postpartum hemorrhage consensus meeting in Geneva, that as well as looking at recommendations for practice, they had a recommendation with regard to monitoring. So their recommendation was that that in routine monitoring, we incorporate an indicator that tracks the use of oxytocin or another suitable uterotonic during the third stage of labor. And we understand that there are very few health systems that are doing this. We do understand that to be able, to move to the point where this routinely gets tracked, that will require certain changes. Again, this is in many countries that we work in, postpartum hemorrhage is the leading cause of death. We heard a number of presentations this morning about the importance of a uterotonic in the third stage in reducing that cause of death. So that's the first indicator. You'll see there's nothing very spectacular about these indicators, but again, these are not routinely being tracked. In our view, we need them. So the second one is cesarean deliveries as a proportion of all live births. And this is an indicator that's been recommended in connection with the EMONC signal functions. But in fact, there are very few countries where this is systematically being reported. And we recognize there are limitations in interpreting this indicator, but particularly when we look at this on a disaggregated basis, it still gives some useful information. Similarly, assisted vaginal deliveries as a proportion of all live births. This is something, it seems to us, it's relatively easily measurable, and along with the cesarean delivery rate, again, this begins to open up the box on what's actually happening, on the care that's actually being provided. This next indicator, you could see this as an outcome measure, but fresh stillbirths as a proportion of all births, this is something that should be quite responsive to good quality intrapartum care. With good quality intrapartum care, we should have considerably fewer fresh stillbirths. And good quality intrapartum care should have other benefits as well, both with regard to the newborn and the mother. And again, in principle, this shouldn't be a very complex or difficult indicator to be tracked in HMIS. And so this is now again, in theory, we could be measuring more, but what we wanted was things that were simple and straightforward. Now finally, at least in some healthcare systems, for certain tracer commodities, you're tracking stockouts. And in settings where those systems already exist, where health facilities are monitoring stockouts, our recommendation is that magnesium sulfate be one of those tracer commodities. And oxytocin, for that matter, would be another appropriate commodity to be included as a tracer commodity. And I think in some of your health systems, you do track some of these commodities. But given again that we've heard that in a couple of countries in the region, pregnancy-induced hypertension, eclampsia, preeclampsia is the leading cause of maternal death now. This is a simple measure that at least gives us some sense of, a little bit more of a sense of the adequacy of service. So what we're aiming at here is a shift in focus away from an exclusive attention given to contact and shifting to giving some reasonable amount of attention to the content or the quality of care. And the reason being that we can only really expect consistent, effective attention given to content and quality if we are consistently monitoring content and tracking it. Just a last thing to let you know where we're at. We are expecting later this year that we'll have a formal statement from WHO along the lines of what I've been talking about today. We're also wanting to find countries where there's an interest in piloting or exploratory work, incorporating these indicators. So I've initiated some discussion with people in several countries. But anybody who's interested in this for your country, where you think that it may be feasible to be trying this out, I'd like to hear from. And my email address is there. So by all means, if this is something that you think that you're interested in, and there may be some scope to move this forward in your country, by all means get a hold of me, and within our smaller group, we'll follow up with you. Thank you.